Gives my great pleasure to sort of introduce Lisa. Lisa's a past professor at the University of Illinois at Chicago at School of Public Health from 2015 to 2018, where she was director of the Illinois Education and Research Center. She started her career as an academic researcher at the University of Minnesota, and you know, she's authored more than 100 peer-reviewed publications and book chapters, delivered numerous platform research presentations, and Lisa's actually going to present something that's very dear to many of our hearts, especially in the midst of this pandemic. And you know, I'm really interested to sort of hear what Lisa has to talk to us about with regard to airborne transmission and also infectious dose of from the exposure to coronavirus. So I won't go on, I'll just hand you over to Lisa. So thanks so much, Lisa, for offering to present.
Thank you. Thank you, Kevin and Marianne. And I'd like to thank Workplace Health Without Borders for the invitation to speak today. As Kevin noted, I'm going to talk about aerosol transmission, which I define as inhalation of infectious aerosols at close range or near the source, in this case, a person who's infectious. I'm going to start out talking a little bit about what the Centers for Disease Control and Prevention say about COVID-19 infection, how it occurs, and then discuss a little bit about what we know in terms of human-generated aerosols and how that informs our understanding of aerosol transmission. I'll talk just very briefly about control banding. I know David Zalk gave quite a long discussion of that, but we did publish a control banding model for aerosol infectious diseases. And then I'm going to talk a little bit about infectious dose and the role that I think it could play in helping us better understand exposures and the impact of different controls on exposure. So starting off with aerosol transmission of SARS-CoV-2, which is the organism that causes COVID-19, here's the guidance that CDC has on their website. And I've highlighted or colored certain, bolded or highlighted certain aspects of this definition. So they say it's person to person, which I agree with, and is thought, and certainly the amount of clustering that we're seeing in indoors, clusters in particular, would support this mode of transmission. And it seems to be that it is between people who are in close contact with one another. CDC says within 6 feet. I'll talk a little bit about that in a minute. And what's interesting, though, is the next couple of statements. Through respiratory droplets produced when an infected person coughs, sneezes, or talks. And I highlighted talks because that is not a traditional mode of part of the definition of droplet transmission. And then the second piece is these droplets can land in the mouths or nose of people who are nearby or possibly be inhaled into the lungs. And that second piece that I've highlighted is definitely not part of the traditional definition of droplet transmission, which is thought to be a propulsion of large droplets directly into the face, the mucous membranes, the mouth, the nose, and the eyes. They also do note another important piece of the puzzle, which is that COVID-19 appears to be spread by people who are not showing symptoms, either asymptomatic or pre-symptomatic. And I will talk a little bit about that again, but I do think that we don't exactly know how many people who fall into that category, but we do know that they seem to be infectious, although they are not symptomatic. So I think it's in the context of an epidemic or an outbreak organism, it is not a good idea to rule out any particular mode of transmission until you move along in the epidemic a little. So these are the traditional, these top three are the traditional modes of transmission for particles, at least, or infectious respiratory disease that traditionally infection control prevention people will discuss. Contact being transferred from an infectious source or contaminated object to the mucous membranes. droplet, as I mentioned, which are large droplets propelled into the face and the mucous membranes. And generally, this is not thought to involve inhalation. Airborne, which is really the only form of transmission that encompasses inhalation, but is thought to be to smaller particles called droplet nuclei that occur it occurs only far from the infectious source. That's somewhat of a perversion of the Wells understanding of droplets and droplet nuclei, but in the current paradigm, that is the definition of airborne. What is not part of this paradigm is that aerosols, smaller aerosols, can be present and inhaled near the source, and that is what I and others have labeled aerosol transmissible or aerosol transmission. It's true, however, in the context of COVID-19, while we don't rule out any one of these, certainly some of them are more likely than others. And I agree with CDC that contact does not seem to be very important. In fact, CDC said early on this was likely not to be a very important mode of transmission, despite there are many and extensive recommendations for cleaning. And in fact, recently they downgraded this mode of transmission even further. They do say that droplet transmission is important, but I would suggest that the data indicate that this may not be as important as everyone thinks, and I will talk about that in a minute. And CDC says that airborne transmission is not very important, but I would say that that possibly is a possibility, and I'm not sure that we should entirely rule it out, because this particular coronavirus seems to be fairly hardy in air with a half-life of about 2 to 3 hours, which would suggest that if it's in smaller particle, if it's the virus is carried in smaller particles, you could have transmissions at some distance from the source. So airborne, in the context of very long distances, is perhaps ruled out. We aren't seeing transmission room to room necessarily, but we are seeing transmission in space, within spaces, and at some distance more than 2 to 3 feet from a source. And as I've outlined here with a red circle, I think that aerosol is probably a very important mode of transmission, not being given enough consideration. So I'm going to talk just a little bit about what happens what we know in terms of aerosols that are generated from people. And back in the 1930s and 40s, when William Wells and Bill Riley and others were measuring particles from people, I should note that they didn't have the kind of instruments that we have today, or the analytic methods that we have today, that really give you much better insights as to what kinds of particles and what sizes and what's the nature of these particles generated by people who are infected. And in particular, we can measure much smaller particles than previously. So I think it was possible to measure down to about maybe 4 or 5 microns using some of those earlier methods, which were mostly light scattering, or using visual methods, or using settling plates and centrifugal samplers. But these smaller particles, and so I've illustrated those here, we actually find that people generate particles, speaking and coughing, as well as sneezing and breathing, across a very wide range of sizes, from less than 1 to greater than 500 micrometers. And what's interesting as well is that we see similar size distributions generated while speaking and coughing. If we think about the physics of human-generated aerosols, and more is understood about that as well, the lungs and the larynx actually play a fairly large role in the generation of aerosols during speaking and coughing, which is probably why their size distributions are quite similar. And there are 2 primary modes that occur around 1 to 2 microns, and then around 100 to 200 microns, as illustrated here. It has been long known that while the size distributions are similar, the concentrations of people generate can vary greatly, and this is just one illustration of that. In general, this also shows that people generate more particles when they're sick than when they're well, and that shows as a comparison between the darker bars on the left, where these are people with influenza, and the lighter bars on the right, where these are people after recovering from influenza. And only one case, the person with the largest number of concentrations, are you seeing people relatively the same concentration. But what you also see here, and which is more important, I think, is that people are highly variable. Now, you do see studies, people will discuss in studies something called super spreaders, and probably subject number 5 here would be considered a super spreader in that context. But I guess I would argue that these subjects are simply illustrating the diversity that's typical of biological organisms. And it's the same diversity we might see in the height of people, for example. So the fact that some people generate more particles than others, rather than discussing this in the context of super spreaders, may help explain a few of the super spreading events that we see. But I suspect that it is not just super spreaders who are responsible for all the clusters and super spreading events that have occurred around the world. And I'll talk a little more about that in a minute. What this graph on the left shows is that speech generates lots of particles, and they are generally smaller. Now, this study didn't use methods that sampled greater than about 20 microns. But what is more important here is that you can see that the size distribution is about the same, but that the concentrations are higher as people talk more loudly. And so if you think about a good example might be the choir. There's been a couple of outbreaks with choirs practicing or singing. And singing obviously can be both a soft and a fairly loud activity. You can imagine the number of particles that might have been generated by even just a single individual in a choir. So you obviously could get very high concentrations of particles among people who are in close proximity. The table on the right shows what happens in terms of particles in still air. And still air is a simplified situation, just to illustrate for you that if you release a particle at about a meter, about the height of a person, in still air, you wait for that to settle. Now, obviously, particles generated by people have a lot of mucus and water, so they will evaporate. But as you can see, some of those particles are smaller, and I've highlighted the box that outlines the smaller size particles to show you that over the course of in the time it takes to fall 1 meter, it can range from an hour to 3 days. So obviously, you add a little airflow to the situation, and that may change the nature of settling, either to increase it, but actually probably more likely to, either to decrease it by causing settling to occur more rapidly, but more likely to increase it by causing distribution of that particle throughout the space. A good example, if you've had a chance to read the recent analyses of the Guangzhou restaurant outbreak, where it was an air conditioner generating an airflow that basically was a sort of a spiral in one small space in that restaurant that picked up infectious particles generated by one person sitting at a table nearest to the air conditioner, and essentially transported those particles around and around in a sort of circular fashion, exposing pretty much everyone who was at that table and the tables nearby. And so you had infection only occurring in that one space. So the idea that I'm trying to present here is that there are a lot of small particles, and that they don't immediately fall to the ground, as is often posited with droplet transmission. and that these smaller particles can remain suspended and distributed throughout a space for quite a long period of time. In terms of coughs and sneezes, there's been some good recent research and a number of experimental and modeling studies to look at what happens. And basically a cough or a sneeze can be modeled as a turbulent cloud of buoyant gas that contains droplets suspended in it. Those largest droplets behave basically ballistically. They just are propelled outward and are unaffected by the gas flow. But all the smaller particles, the droplets, will remain suspended in that gas phase, and they are carried well beyond what you might expect if they had not been included in this turbulent cloud. This group, Dr. Boribia and others who've done similar work, have shown that these aerosols can be distributed and carried quite a lot farther than the 2 to 6 feet or 3 to 6 feet that people typically describe for droplets. And this shows the same as well. This is a modeling study. As shown in the two graphs on the right, the very large droplets ranging from 100 to 1,000 micrometers can travel up to 4 meters from coughs and less than 2 meters from speech, but the left graph shows that these particles will generally settle quickly, less than 10 seconds. It's the somewhat smaller droplets, less than 20 microns, that can actually travel well beyond 8 meters from coughs and speech, and the very smallest particles, the 2 microns or less, will travel very long distances. So again, the more recent data shows that this 3 to 6 feet or whatever it is that people prescribe for droplet precautions probably really isn't appropriate with respect to human-generated aerosols. And it's important to note, of course, that when we're thinking about exposure, what we worry about is what can people breathe in, not just what is breathed out by an infectious person. This shows the deposition patterns of particles in the various sections of the respiratory system, depending on their particle size. I added the line over here at 0.1 because really we're most interested in infectious aerosols with particles that are greater than about that size, and actually probably a little larger than that. Now, as you can see, larger particles are generally deposited in the extrathoracic region above the larynx, while the smaller particles will penetrate into and deposit in the tracheobronchial and alveolar regions. We don't exactly know yet how COVID-19 or SARS-CoV-2 causes infections, but we do know the receptors, the ACE2 receptors, are found throughout the respiratory system, and we do see both upper and lower respiratory infections, with the lower respiratory infections being more serious. And this would suggest that we should be concerned with particle size over the full range of deposition, as shown here. So if we think about, now I'm going to talk a little bit about what is the exposure. And I tell industrial hygienists who are trying to figure out how to solve this problem to think of it as the outdoor air pollution folks describe vehicles as the people inside a workplace or wherever it is you're worried about are basically mobile point sources. Each person is a potential source. They're mobile, and there can be many of them. Keeping in mind that you have pre and asymptomatic transmission, and some investigators have estimated that this could be up to as much as 40 to 50% of transmission. That means minimal coughing and sneezing, so lots of these smaller particles from talking or breathing. The concentrations obviously will be highest in the immediate vicinity of the source. Any occupational hygienist would know that. And if we think about each person as a source, then the concentrations nearest each of those people will be the highest. And this is also, unfortunately, a hazardous aerosol that has no occupational exposure limit. I won't spend a lot of time talking about how one would go about formulating an occupational exposure limit for an infectious respiratory organism, but just at this point, we obviously don't have one. So how do we make decisions in the context of novel aerosols? As I noted earlier, David Zalk did give a very in-depth discussion of control banding, and I think he even mentioned the paper that Dr. Margaret Seetsam and I wrote with several other investigators at NIOSH and CDC on using control banding for an aerosol infectious disease and during outbreaks. But basically, we already have tools such as control banding for hazardous aerosols that have limited information about toxicity. And two that come to mind are the pharmaceuticals, which were really the first place in which control banding was applied, where most of them do not have exposure limits, probably never will have exposure limits. They're bioactive, they can be highly hazardous, and you might have a little animal toxicity information. But it is possible to allocate pharmaceuticals into different categories and to allocate exposures into different categories and make decisions on the basis of control bands about what to do to prevent exposure. Nanoparticles has proven to be even more complex problem in some ways than pharmaceuticals, because they are made of a wide range of materials, some of which are very toxic. And there was very limited animal toxicity at the beginning. It's a little better now, but it's still a fairly complicated problem, and yet we've been able to resolve many issues of exposure using control band. So I would suggest that control banding has a place with respect to aerosol infectious diseases. I've put the citation here at the lower and at the bottom of this slide, a control banding framework for protecting the U.S. workforce from aerosol transmissible infectious disease outbreaks with high public health consequences, which was published in December of 2019, almost as if we were getting ready for COVID-19, although it was in the context of influenza that we were thinking about this particular paper, and knowing during novel H1N1, for example, that we did have problems with supplies of PPE and other important control measures. So basically, we proposed a fairly simplistic approach to categorizing exposure that's basically just says identify the likelihood that a work task will involve interactions with infectious people, and then identify the amount of time during a shift that you might, that those encounters might occur. And this basically gives a 3-level rank of exposure. We proposed combining that with the NIH risk group or risk rank, and the risk group for SARS-CoV-2 is 3, suggesting it's because it's an agent that's associated with serious or lethal human disease, and for which preventive or therapeutic interventions may not be available, certainly not a vaccine, and for many situations, not even very useful preventive or therapeutic interventions. So the risk group 3 ranking then gives you, in combination with an exposure rank, what is the control band. We basically, in preparing this paper, we knew we wanted to apply the hierarchy of controls, but when we looked at hierarchy of controls, there was a lot of disconnect between what infection control people think of as hierarchy of controls and what occupational hygienists think of. So we decided to avoid those terminology misunderstandings or disconnects, and propose simply to think about control methods in the context of 3 things. First, as source controls, meaning doing your best to either eliminate or control right at the source of the aerosol being generated. Next, the pathway controls, meaning interrupting the path between the source and a receptor. And finally, receptor controls, which are basically personal protective equipment. And as everyone knows, these progress from the best to the worst in terms of control measures that we should be using. What I thought was a little fairly innovative in terms of Margaret's approach to this was to allocate in terms of the different control bands. What should one do with respect to these three kinds of controls, source, pathway, and receptor? And the purpose for this paper was to manage personal protective equipment and other similar supplies for those who most need them, frontline healthcare and other essential workers. So the goal is for all other workplaces to be planning in the context of an infectious disease outbreak using source and pathway controls and a combination of those as much as possible. And only as you move into the higher bands are you allowed to consider the use of receptor controls, and only after you've implemented all those other controls first. So I'll give just a quick example. First, one example. We proposed a number in the paper, and I'm picking a workforce that has been shown to be at high risk for infection from COVID-19, transportation workers. So if you think of a city bus driver, they interact with a lot of people every day, many of whom may be infectious and asymptomatic or pre-symptomatic. It's not possible to know who is or who is not, and they work long days, 8-hour days, or sometimes more. So if you look back at that exposure and duration, this gives a level of exposure of E3, which is the highest. In the context of the control banding, this puts this job at control band C, which isn't surprising given the high rates of infection that we've been seeing. So basically, in terms of source controls, probably those are the hardest to come up with, although because you can't really limit who boards the bus, although you may be able to limit the number of people who board the bus. In terms of pathway controls, one of the best options might be to simply enclose a bus driver in a separate and ventilated space, such that they do not share any of the air that is generated by the people on the bus. My understanding is buses, airflow in buses is usually from the back to the front, which in the context of an infectious aerosol outbreak is probably the worst situation. So clearly the bus driver will be at highest risk given the airflow. If the bus driver does need to enter the main section of the bus, this is the point at which they might be required to wear a respirator. And sometimes that is a requirement if they need to assist a passenger or fix something on the bus, for example. So that's just a short illustration of how you might use control banding to begin to understand exposures and rank different kinds of jobs and even begin to select different controls. The big problem, though, is that we don't really have a lot of information about the actual level of control of an exposure. And so I'm going to talk now just briefly about infectious dose and the role that I think that might play in the context of thinking about exposure. So if we could quantify that level of exposure, we could start to compare one intervention with another. Even if we didn't have an exposure limit, we might be able to use this concept of infectious dose to model somewhat more accurately what the effect of separate controls might be on minimizing exposures. If you think about dose, what we do know for coronaviruses, and SARS is perhaps the best example, MERS as well, because we do have more information about what happened during the outbreak of SARS. It did appear that people's the highest risk of infection was in the hospital, and the highest risk of infection in the hospital was during aerosol generating medical procedures. We did also see, so it's similar in that COVID-19, we're seeing higher attack rates in indoor clusters, which I would suggest is a lot like an aerosol generating procedure in that it is can be a higher concentration or event. And so if you think of this as a concentration times time issue, which is basically what dose is, that's a way of thinking about exposure and incorporating concentration and time into our calculations of exposures. So this is not published yet, but a fairly good article by Dr. Evans at MIT, and I have talked to him about his calculations. It is available as a preprint, and he's basically trying to, he was asked to see if he could estimate what exposures might be in different settings, mostly for researchers, in the context of bringing people back to work and getting academic researchers back into the lab. The aerosol transmission is basically inhalation of infectious particles. The probability of being infected thus depends on inhaling something called an infectious dose, which we might define as the number of virions needed to make infection likely. So, and we know that those are a function of where your particles land in the lung, as well as the likelihood of that deposition, based on the graph I showed you earlier. What's important to understand about infectious dose is that it doesn't necessarily imply illness, meaning symptoms and disease. As we know with COVID-19, you can get infected and you can shed virus. Quite a lot of shedding can go on before symptoms occur, or even if symptoms never occur. We don't really know what the infectious dose for COVID-19 is, but Dr. Evans estimates about 1,000 virions by analogy to influenza and other coronaviruses. And I think reading the same papers that he's read, I think that this seems a reasonable estimate. So that it isn't, unfortunately, just as easy as saying 1,000 virions. So what we also need to understand is what do people actually shed in terms of their viral load. So this is another piece of the puzzle. This is sorry, I'm going to go back. I skipped this slide. So in terms of viral load, what that is often defined as is the RNA copies per milliliter of sputum, or milliliter of liquid in sputum. It would be RNA copies, but RNA copies are simply the number of RNA copies measured by PCR. That doesn't really tell you much about whether they are viable or not. And but we know less, and we know a lot less about viability because it's a difficult thing to measure for viruses. It requires different sampling techniques, and it requires different analytic methods. And in the context of an infectious organism that's causing a pandemic, to do you can do that kind of sampling, but to do the analysis, you actually have to have a biosafety level 3 setup. So that isn't going to be something we're going to be doing either regularly or quickly in the context of this pandemic. So we're left with viral load, which is a fairly easy thing to sample these days. We know that this is another group, Dr. Maraska's group in Queensland, Australia, who's posited that your viral emission rate is a function of that viral load in your sputum, how much air you exhale per breath, what your breathing rate is, how many particles you emit per breath, and what the volume of that particle is, which is basically a function of particle diameter. Most of those things are known, including viral load in sputum, which can be measured with sputum samples or with swab samples. And so you can estimate a steady state concentration based on assuming a viral load in saliva about 1,000 per nanoliters, an aerosol generation rate, which varies for breathing, talking, etc., but is known, whatever the room ventilation rate is, which usually can be either measured or estimated based on engineering specs, and then what we know about in terms of loss of particles due to settling or decrease in viability, both of which are the first of which is known, the second of which is fairly well known for SARS-CoV-2. And in many spaces, settling is likely to be fairly minimal if it's well ventilated. As I mentioned, the half-life is about 2 to 3 hours. So you can basically make an estimate of exposure, which is a function of somebody's breathing rate and the concentration in the air and the time that is being spent in a space. So I'll give you an example. This comes from Dr. Evans' paper. In a typical office with a breathing rate of, a ventilation rate of 10 cubic meters per minute, and just one infectious person who's mostly breathing, but occasionally talking, you get a steady state concentration that reaches about 10% of the infectious dose at approximately 100 minutes. And he picked 10% of the infectious dose. I think that's a reasonable safety factor, given that people don't just spend time in their office, they go to other places, and they spend time at home where they might also be exposed to people. And if they travel between work and home, they're spending time on public transit or in other spaces with people. So it's best to think of your work setting as trying to limit, building in a safety factor to limit somebody's exposure. To safely share an office with that person for 8 hours, though, you would need a ventilation rate of 5 times as much, 50 cubic meters per minute, which is not that easy to reach. So, and obviously the more potentially infectious people in the room, the greater the concentration, the less the time you can spend that any non-infected occupant can spend. We can also do similar calculations for transient events, and typical things that people are worried about in going back to work, or what's going to happen if I go in the bathroom, or what's going to happen if I go in a elevator. In the context of a bathroom, most are considered fairly well mixed environments with good ventilation. That may or may not be true in any particular context, but if you assume an infectious person enters the room, spends about 5 minutes, maybe coughs a couple of times, Dr. Evans estimates you need to wait approximately 15 minutes to allow that room to clear before the next person enters. So it hasn't had a chance to reach steady state, but there is a concentration that occurs in that room that basically needs time to clear out using ventilation. If you increase the ventilation to 350 CFM, which may or may not be possible, you could possibly eliminate the need for wait time between people. Elevators are generally considered poorly ventilated environments. A sneeze in an elevator, Dr. Evans estimates, would require waiting for approximately 5 air changes. And I looked it up, elevators seem to be about 1 or 2 air changes per hour. That means that you basically have to wait quite a long time between elevator riders. So I hope that what I've been able to show you is that there are some advantages in, even if we don't know everything about infectious dose, there are advantages in using these kinds of calculations. You can illustrate the impact of ventilation, distance, contact time, number of people in a space. You can calculate safe contact and necessary wait times, building in safety factors. And you can, I didn't show this, but you can start to look at the effect of different interventions, such as the face covering, which has a protection factor of less than 2, a surgical mask, which has a protection factor of about 4, and a respirator, which has a fit factor of about 100 or a protection factor of 10, and portable air cleaners, which can offer more air changes per hour and filtration as well, so they can be used to enhance ventilation. Basically, that's pretty much all I have to say, and I'm glad to open this up for questions.
Well, thank you. Thank you very much, Lisa. That was, I think everybody found that fascinating. Also judging from the activity in the chat box, there's a lot of interest and a lot of discussion, which is what we want to encourage.